title?
No.
Yeah. Okay.
Good evening, family. Thank you very much for joining us. This is In His Grace and Mercy Ministry. So thank you for joining us. So I'm just going to wait for a moment so that people can come in and so that we can start, and and then I can introduce the speaker for tonight. Just come in and say good evening as we usually do, family, so that Sibona Utinde Lapo Bazalwan, and then we can start and have a discussion. If you are joining in on the other handle, Yamatobani, I might not be able to project your question directly on the screen. So the best thing is that join on In His Grace and Mercy platform directly so that you can ask your questions and you can get your answers directly. Otherwise, I'll have to read them and relay them. So just come in and say good evening so that we can see Nilapo so that we can start. Otherwise, enjoy the song at the background. It's CD Bang Marines headquarters. They call themselves Germany. As you're coming in and sitting down, please enjoy. Thank you very much. I think we're gonna start so that we can respect time and we can stick to the time. Before we start, as usual, I'm gonna open with prayer, just thanking God that we're here today and we're counted amongst the living, and we are about to teach isizwe sakhe, and we are doing this from the goodness of our heart to empower, to impart knowledge, to save lives, to touch lives. And this is In His Grace and Mercy. This is how we do. So that we can pray. Thank you, Lord, this evening again. We thank you once more, dear Lord. You never cease to amaze us, dear Lord. In the midst of everything, dear Lord, you come through, dear Lord, to be with us, to share and to support and to make sure that whatever we ask for, you give it to us, dear Lord. In this midst, dear Lord, even if we have to be patient in most cases to receive what we ask for, dear Lord, we know that in you, whatever you said must manifest. And this evening, we ask you, dear Lord, to be with us as we teach, as we make people aware of certain things that can cut short their life, dear Lord. We know that the power lies within you, and you said that isizwe shall perish because of the lack of knowledge. So we are imparting knowledge today. Be with us so that we can do it from the depth of our heart, not for any gain, for anything, dear Lord, but to make other people gain. And this is how we thrive. In Jesus' name we pray. Amen. Sabang, thank you very much for those that joined us. Thank you very much. Just do come in and say hi. So that's one of the corner. You know, when I made the ad for this evening teaching, I made a challenge to men, because this prostate cancer talks to men, and you know, I wanted men to prove me wrong, that they really do care about their health, and they really do care about what happens to them. And then as that they show that by joining in, you know, so that they can show that they really care enough about themselves to worry about their health. You know, I know that in most cases we don't check it until it stops working, and then once it stops working, we start running around crying. But I know very well, even our cars, we don't push them to a service center. We go book them, we leave them there. So we drive them to a service center. Even if they are driving, we still leave them there to be serviced, so that they can be fully functional all the time. So this is the prostate cancer awareness that we are making, just for men to be aware that there's a prostate cancer that is there, that our urologist, Dr. Gwiliza, that I'm going to introduce now, who's going to teach us about it. And then we can ask questions. We can then ask questions, as we usually do. And so that we can cover those things, those myths that are there out there that you've heard about pertaining to prostate cancer. And before we start, let's be generous and also share with. Thank you very much, and also share the link with other people. You know, I promise you, when you share the link, your data is not gonna be gone. You know, your nothing is gonna happen to your phone. You're not gonna get a virus. Just share and share, Bazalo, and let's show love. So let me introduce our speaker for tonight, who now appears on our screen, Dr. Gwiliza, one of the urologists who is going to fully introduce himself. He's based in GP. He qualified in University of Pretoria. That's where we met on the corridors, trying to be students again and again and again. I usually say as doctors, we stop studying when we get to the grave. So that's what happens. So that's where we met. This is a Dr. Gwiliza, urologist. So Dr. Gwiliza, I'm going to ask you to introduce yourself in a few lines, and then I'm going to let us start, and so that you can teach us about prostate cancer this evening. Over to you, sir. You can introduce yourself.
Good evening, ladies and gentlemen. Thanks, Dr. Kekana, for the invitation. As you've mentioned, I'm Dr. Gwiliza. Originally from the Eastern Cape. Graduated my undergrad at the University of KwaZulu-Natal, and now based here in Gauteng, to be precise, in Pretoria. Working both in the public sector and in the private sector, meaning at one military hospital. Then I'm also at Zamoguhle and at Heart Hospital. And yes, and thank you for the invitation again.
Okay. Thank you very much, Baba. Thank you. So if if after this you have any questions, or you know where to find him, Heart Hospital is in town, and there's Zamoguhle, which is in Tembisa, is both in private and in public sector, in one military. So thank you very much. So I'm going to share your slide. Please do ask questions, so that at the end of his presentation, we are going to so at the end of his presentation, we can then ask questions. He's going to present just like we did with the breast cancer awareness. He's going to have his PowerPoint presentation. Then from there, we can then ask questions. Do you want me to share your presentation for you, or you'll try and share it?
I'll try and share it from my side.
Okay. It's fine. So please do. I'll see it at the back of the screen once you started sharing it. Yeah, oh, I can see that. Okay, thanks, Bob. I think you are good to go. Over to you, sir. Educate us. I'll be at the back of the stereo listening to you.
Okay, thank you for this. As we all know that no time for us to reflect on men's health and really intensify health education. But it's not the Movember movement is not only about prostate cancer. It talks on issues on men's health, with the COVID that was here now, we know that lifestyle diseases such as diabetes, hypertension, obesity really play a big role in terms of mortality even in other diseases. Prostate cancer is a very common cancer. Actually, it's the most common cancer in the middle-aged men, and it is the second common cause of deaths from cancer. Then the leading cause of death it's in men, it's actually lung cancer, then prostate cancer. But then the good news about this is survival is improving, and this is owing to early diagnosis, better health education, and also advances in treatments. And as the treatments are advancing, they're becoming less toxic, meaning patients can then tolerate the treatments better, and because of that, then we're getting better outcomes. So what is this prostate? So if we're looking at this, trying to get a pointer there. If we're looking at this diagram, which is labeled, we'll then see that would be the bladder, the urinary bladder, and that along that would be the urethra, or the pipe that the urine will be passing through, and then the prostate will be just under the bladder, which then and then this prostate is a gland that produces the fluid in the semen. That will be the fluid that you will then see in the ejaculate. Part of the fluid is from the prostate. Another part of the fluid is from the seminal vesicles that are seen just behind the prostate. Risk factors for prostate cancer: number one, it's age. The older we get, the more likely you're gonna get prostate cancer. And some research says if you do live long enough, you will get prostate cancer, because we know that 80-year-olds, majority of 80-year-olds will have prostate cancer. However, in that age group, it is usually not as fatal as when you get it at a younger age. Race: Black people are at more risk, and it tends to be also more aggressive within the Black population. Asians have the least risk. People with family history of prostate cancer also have a higher risk of getting prostate cancer. Obesity, again, lifestyle diseases coming as a risk factor there. Western diets: most of us, we're eating McDonald's also we're feeding our children mostly Western diets, and all these have health implications. And this has also been shown that people with a study whereby people in Japan, which has one of the lowest incidences of prostate cancer, but once they move to the United States, within one generation, their risk of prostate cancer increases significantly compared to their cousins that they've left in Japan. What will be the symptoms? Again, increased frequency of going to the bathroom, especially at night. Someone who wakes up at night, you shouldn't be waking up to go to urinate. And then people who wake up 3, 4, 5 times to go and urinate. That could be a symptom. The stream become weak, blood in the urine, blood in the semen, getting persistent lower back pain. You must always think of prostate cancer, because once prostate cancer moves and from the prostate, it really likes moving towards the bones in the back, and then you can get this persistent lower back pain. And then other troubles with urination, like the urine is burning, you've got frequency, you really need to you struggle to initiate urine, you're pushing when you need to urinate, because urination, you don't need to be pushing. And then also the incomplete, get a feeling that although you've urinated, but there's still some urine that is left. And I must also mention that these symptoms are not specific to prostate cancer. They can be other, they can also be due to other diseases within the urinary tract. And then others that are not mentioned here would be erectile dysfunction. So how do we then diagnose prostate cancer? I think Dr. Kakane mentioned it nicely, that you do not need your car to stop before you take it for a service. And although we had mentioned all those symptoms that are associated with prostate cancer, however, most of people will not have symptoms. And that is very important, that most of the time, by the time you get symptoms, it is usually at a stage whereby you cannot get curative treatment. So therefore, it is always important, once we reach the age of 40 years or 40, we can visit our local clinic, a GP or a urologist, who will then do a blood test. The blood is called a PSA, or prostate specific antigen blood. I know we all do not like needles. And then the second thing will be a rectal examination, which many people really feel they do not like it, but it can really save lives. So basically, the doctor will put their finger from the anus into the rectum, and then there is the prostate, and then he is able to then feel for the prostate. And then you can see, you can only feel almost the back part of the prostate, and that is actually where more than 85% of the cancers will be coming from, not from this area in the front or towards the bladder. The majority of the cancers will be in this area, so he will be able to feel it. And most of the time, people will ask, wouldn't just a blood test be enough? And unfortunately, you'll find that the most aggressive cancers, the blood test may be normal, but then the finger test will be abnormal. So that is why it is important to do them together. Then if any of the two are abnormal, either the blood test or the rectal examination is abnormal, then you're gonna be sent for a biopsy, whereby then you're gonna take small pieces from the prostate again. So in this example, they've got this would be an ultrasound machine, which will then give us guidance on where to take pieces of the prostate. And then this will be the needle that will then take small pieces of the prostate. This can be done either in theater with you sleeping, or it can actually be done with you awake, a little bit uncomfortable, but it can be done without going under general anesthesia. And what's next? If then the biopsy comes back and then it confirms that there is a cancer, now we need to determine whether the cancer is just localized in the prostate, or it has spread to other organs. So we do this by checking the bloods. So in the bloods, they'll check your liver, they'll check other bloods that may tell us that maybe the cancer has gone to the bones. Then there will be scans that can be done, that should be done, which include bone scan, MRI, and PET-CT scans. So depending on the risk and what the bloods and the histology have really shown, then your doctor will then decide on which of these modalities they will use. So now, what happens if the cancer is only in the prostate? So we've got a number of options. And then for these patients, what you would really want is to go for a curative treatment. And that is why it's very important, again, to go and seek help before you feel the symptoms, so that we can be able to manage the cancer curatively. So one, we can remove the prostate, total removal of the prostate, what we call a radical prostatectomy. And then of course, it does have its own complications, because number one, you have to be put to sleep and to be woken up. And then secondly, you may end up with erectile dysfunction after the procedure, or you may end up with leaking of the urine. Those are some of the complications from the radical prostatectomy. Another way would be to do radiation. The one way would be just to insert seeds, small seeds, into the prostate that then radiate the prostate. But then again, you really need to have a very low volume disease, early disease, for you to be able to qualify to have such treatment. And then the next one would be radiation. So whereby you'll be in a machine like this, whereby you radiate the prostate. And then, so this therapy will include going into this machine for up to six weeks, Monday to Friday, for about 20 minutes for each session. And then, of course, the oncologist will then say whether you need more or less of these. And again, it does have its own complications that if you will remember from the previous slides, where we're showing the prostate, then the radiation will be going through from the front into the prostate. So some of the radiation may radiate the bladder, some of it may radiate the rectum, so giving you a little bit of problems into the bladder, such as urgency, whereby it becomes difficult to hold in the urine, or maybe getting blood in the urine, or urgency for the stool, or blood through the stool. But I must also indicate that the newer machines, again, the toxicity from the radiation is becoming less, and then the patients usually do much better than what patients would have done years back. And then another one would be to do nothing. So basically, for very select patients, you can say, okay, I do not want to remove the prostate now, doc. I don't want the radiation. But then these would be very select patients with very, very early disease. And then for this patient, you can say, okay, we're going to follow you up, strict follow-up. But as soon as something happens, or the cancer seems to be growing, then we're going to manage it either by radiation or by the removal of the cancer. And of course, there will be a certain group of patients, maybe your more elderly patients, who may say, listen, this cancer is just in the prostate. It may not do much for me for the next couple of years, and I'm old. So I would rather not do anything. But once it has spread into other parts of the body, then you're gonna treat it at that time for any symptoms. So in this picture actually is what used to be the future, but now it's a reality. And we know that even the government in the Western Cape have bought two of these for Hoteskill Hospital and the Tigerberg Hospital. So here, the patient will be lying again on the operating table. This is a robotic machine. So this will be the robot that will be doing the operation with multiple arms. And then these arms, they will then create small incisions into the abdomen, place the instruments into the abdomen, and then the surgeon will be sitting very far away from the patient and operating the patient. And then with these machines, we know now doing prostatectomy, less complications, and actually, patient will be back at work sooner than your if we are done in the old way where we open the abdomen. And what happens if the cancer has spread by the time you are diagnosed? First of all, we need to treat the symptoms, whether it's the urinary symptoms, pain from bone pains, then we need to treat that. Secondly, we need to then we do hormonal therapy. So the hormonal therapy would include that we need to decrease your testosterone levels because we know that in the presence of testosterone, prostate cancer becomes worse. So now we need to do to remove the testosterone, and this can be done in two ways. It's either through a medication, which would be 3 or 6 monthly injections, or surgically, whereby we remove the testes, both testes. Another way would be to go for chemotherapy, and then the chemotherapies are really improving. Tolerance is getting better on the chemotherapies. And the last part there would be nuclear medicine. Because we know currently nuclear medicine has really been helping us in terms of imaging, giving us where the cancer is, where if it has spread, like things like PET CT scans or bone scans. But now using the same machines, you can actually give a different nuclear isotope that will then go and attack the cancer cells. And usually it's it's a more of a gentle therapy and with very less toxicity. But mostly in South Africa, this is really left right at the end of therapy. But I'm seeing now that they are really coming in front now, and in terms of us using this modality as treatment. So that would be what I would have on in terms of the prostate cancer. But then I just thought I would just share just on this one slide about this thing called benign prostatic hyperplasia, which basically is a known cancerous growth of the prostate. It will give you same symptoms as the prostate cancer, and actually it gives symptoms much earlier than the prostate cancer. So usually patients with more pronounced symptoms actually have the benign prostatic hyperplasia. And it is this one is not it's not a life-threatening disease. And then this will be my last slide. I just wanted, because most of the time when people think of what urologists do, they often think we sit somewhere and we're giving out Viagras, but there's more to it. So the urologist actually looks at, and we're not male gynecologists, because we're looking both the health of both men and women, in terms of looking at the kidneys, the ureters, the bladder, the urethra, looking at infections, stones, cancers of those organs. We also deal with fertility issues, male-based fertility. And in terms of just one word on fertility. I know most of the time, once there's a problem about fertility, it's always the lady who gets blamed, and actually, most of the time the blame can be shared equally between the men and the women. And then I just put there things like vasectomies in terms of family planning, and then of course the sexual health issues. Thank you.
Thank
Dr.
you very
Kekana.
much, Baba. Thank you very much. You can stop sharing your screen so we can have a chat. You. Thank you. Thank you very much. I'd like to thank you, Dr. Guliza, for really your help. We are now enlightened. I've got a few questions of my own, and I asked them to ask few questions. We'll see if the questions will come through. But I'm gonna ask questions so that we can re-emphasize on certain things that we missed. And let me start by thanking you to go back and educating our people what a urologist is and what a urologist does. So I'm glad that you opened that kind of worms. Next time when we talk about family planning, we'll call you, Baba, so that you can take us through vasectomy and all those things and fertility. It's okay. I think you did well by outlining what a urologist does so that they can understand. You know, I have a question that I want you to like re-emphasize. You said, and if I heard you very well, you said that sometimes you can have prostate cancer without any symptom because it's a disease of sort of age, so to speak. So therefore, and sometimes even when the blood results in an aggressive cancer, the blood results could be normal, but you could have an aggressive cancer with a normal blood results. So that's what if I heard you properly. Now the question is, if then you can go without any symptoms that you have listed in incontinence, blood in semen, or blood in your urine, and also blood in your stools. If you don't have those, and you are now worried that you could have, and possibly maybe your father had or your uncle had, at what age? Now the direct question is this: at what age must I now start getting worried and talk about going routinely to check for prostate cancer, as ladies do check for breast cancer? When can I go? Can I do routine checkup, and if yes, when?
Okay, thanks for that question. Once you reach age of 40, at the age of 40, we need to start doing routine checkups. So by means of routine, because it becomes a bit of a difficulty, just a rule of thumb, we often say yearly, but then some of the times your doctor may, depending on the results, you may have to repeat the PSA earlier than that yearly, or it may be even later than that, maybe after 2 or 3 years, that you have to repeat it. But once you reach the age of 40, you need to go and check your prostate cancer. And then the issue of when to return, I think it's best left to the healthcare worker to say, okay, for you, just come back next year or in 2 years' time. But I think the yearly part of it was more because of the ease. Because once something you have to do every 2 years or 3 years, then we often forget, and then next thing you realize it's after 5 or 6 years. And then, but once you know, okay, on my birthday or just a week after my birthday, I'm doing some going for a service, checking my prostate, checking all other things like diabetes, hypertension, then it becomes part of your lifestyle.
Yeah. Okay. I think that's good. So 40, the same way that we talked about breast cancer, and I'm going back. So at 40, go for routine checkup. And I like what you also said. We must normalize that every year. So every year you must thank yourself, possibly maybe around your birthday, you must thank yourself by going for routine checkup, which is what most of us, somebody in my family taught me that on my birthday, when I celebrate my birthday, I have all my blood results on the table for whatever that I'm at risk of. depending on my age. So thank yourself with that as a man, even as a woman, do that. Thank yourself by putting all the results, knowing that around my birthday, I need to go for a checkup. Go and get your blood drawn, check your sugar, check your BP, check all those things, check your urine and stuff, so that you can say, Mauti, Mina, I'm strong. You know what you're talking about. Mina, I'm okay. You know what you're talking about. I always say that ladies trust us with their health, but it seems as if we don't trust ourselves with our own health. But I'm not trying to shoot. I will shoot later. Then the other question that I have is that if I have a prostate cancer, is it curable? And when is it curable?
The answer is yes, it is curable.
Yeah.
And then it comes back to the issue of us going without symptoms, because early cancers are curable. And often most of us don't even know where this prostate is. I mean, I only knew about this prostate when I became a doctor, where it is. And I often say, if someone can really have, if we can go and have very advanced disease of the breast again that you have mentioned, and then the breast, we always see them, someone is washing the breast all the time, but then if you're not actively looking for it, then you miss it on the breast that we all know where they are. How much more for an organ that is really hidden somewhere, and which also will grow while it is asymptomatic, without any symptoms. It will grow, and we don't even know where this organ is.
So now the question is this, which is
It
the
is
question
curable.
that now, indeed. So early disease, early pickup, it is curable, and I like that. So, but now where do I go? I feel okay. Now I'm at that age. Some of us started testing for prostate long ago when we were 40 years. Now we gotten into this. So, but for somebody who's now going to be 40 or who's now 40, and then they want to now start, where do they go? Because we some people can go to the GP and they can go to a specialist referral and everything because of they've got funds. But for any normal South African, where can I start that they will give me help and make sure that they address my worry, which is, am I having a prostate cancer or risk or not? Where do I go?
Your local clinic. You can go to your local clinic. You can just ask in your local clinic that, okay, I've reached this age, I'm not feeling anything, I'm just here to check. They should be able to help you. You can go to your general practitioner, and of course a urologist will also can help. So those three avenues is where help comes from.
Yeah. So you can go to the clinic, you can go to your GP, your general practitioner, or you can go directly to your urology specialist who's going to do all those tests, right?
Yes.
So you can just say, no, I know I'm not feeling anything, just the same way as a breast cancer screening. But Utula is asking a very important question. Uti, do you think the breast cancer is given more attention other than other cancers in Mzansi or anywhere in the world anyway?
I think I would say yes, in a sense that, but the problem, I think, it is also from us, people who work in the space of men's health and also dealing with prostate cancer, that we really are quiet about it. We really do not talk about it. And also, I think also within our families, when someone, I think in one of the slides about risk factors, we spoke about families. And I often tell the families that, because once you've got the prostate cancer, people often think it's such a private issue. I should not share it with other people. But you've got brothers and you've got kids that are boys. And then what happens? Next thing, you have prostate cancer, You do not tell your brother, you do not tell anyone about it. Next thing, your brother is dying from prostate cancer, or even your children at a later stage die with prostate cancer. So I think prostate cancer still does need, we still do need to work on it and really work on the in terms of health education. And I think another problem with it, it becomes with the breast cancer, we can always talk about it anytime, anywhere, anyhow. And then prostate cancers and testicular cancers, penile cancers, we need to have age restrictions sometimes and say, no, if it's in the church, let the children leave first, and or let's do it at in the night. And then that becomes a bit of a problem, that these things, we think they are too sensitive to be taught at certain places.
Yeah, and you are right, and which is why we are trying. You and I, my friend, are trying to break that stigmata that this thing should be discussed in a secluded place, and people are not giving it attention. Which is why we are here giving it attention that it needs, because we know even people who are not even aware that during the prostate cancer awareness, we leave our beard to grow in. That's why you showed that picture of a beard on the side in November. People don't know that when we leave our beard to look like we are lost or we are dirty, is that so that we can remind people, when you see us like this, it's an awareness for prostate cancer. Because yes, we can't see the organ. Sometimes we can't even feel when something is wrong with it, but we have to make an awareness. And that's the question that Utula is asking. It's a good question, and we must start, which is why the next step is that we must sensitize men in a way that even next time when we call men to talk about men's health, they come through, because men really, they haven't convinced me. But nonetheless, let's continue so that we can save time. Lebogang, we've already answered this question. Dr. Kulisa said 40 years, and I'm sure you got this. So at age of 40, we can start checking, right? Advocate also has a question. What are the chances that a cancer has spread beyond my prostate? If so, is it still curable? That's the same question again. So if you pick it up late, it's spread beyond. At what point can you really, prolong life? At what point can you really cap it? Can you still cure it while it has spread beyond? And please outline what does beyond means, because it can be away from the cancer, it can be surrounding structures. So take it like that, so that you can give him a all-rounded answer.
Yes. I think it's quite an important question about what are the chances of the cancer spreading beyond. And this is actually one, in terms of the chances, it's what really preoccupies our time, to looking at the genetics of these cancers. Who is more risk of the cancer to spread beyond the prostate, and what are the genes that are really, really important? And I think one other thing that actually should have been on the slides, that this question has just reminded me of in terms of genetics, is the fact that breast cancer and prostate cancer are linked, because through genetic pathways, meaning then that if you've got a family history of breast cancer, ovarian cancer, your chances also of getting prostate cancer are actually high. And those are the things that we're actually grappling with, to looking at what causes some of the cancers to be more aggressive than others. And then the second part of the question is the issue of what happens if it's a spread beyond the prostate. Then what? So spreading beyond the prostate, as Dr. Kikane has mentioned, it could be two things. It could have just been, it has just moved out of the prostate. So what we call locally advanced disease. So it's still around the prostate. It just has grown out of the prostate, from outside the prostate and gone into the other organs like the bladder on top, seminal vesicles, but it's still around the prostate. Then you can get then what we call distant metastasis. So this cancer has actually gone out now of the prostate, and this it will do in two ways: via the bloodstream. So now it's gone, it moves, goes to your lungs, to your brain, but mostly the prostate cancer will go to the bones. That's why it was important in the symptoms when we mentioned persistent backache. It goes to the bones and it lags going to the bones at the back. And actually, you can actually get paralyzed from that. So that will be what will happen. And then the issue of, is it still curable once it's like that? No. With what we currently know at the moment, once it has spread beyond it is not curable, but we can control it. And the good thing about the prostate cancer, in terms of controlling it, that can be years of control, more than 5 years, 10 years of us controlling the prostate cancer through hormonal manipulations, chemotherapy.
Yeah. Thank you very much. I hope so the advocate is well answered. Like we said last time, when your family member passes on, by you trying to understand what was the cause, it's not you being nosy or getting the abantu. It's because if somebody in your family had breast cancer, there are two genes that I know of that when you have breast cancer, if you have those genes, you also have a higher than normal or higher than an average person or higher than average population person for the risk factor of a prostate cancer, those are BRCA mutation genes. So remember, we spoke about BRCA mutation genes that you have in females. So if your aunt had a breast cancer, or your other aunts or other family members you have a breast cancer at home, you can't only look at the breast cancer only and say that you are at the risk. As a man, you're also at the risk of a prostate cancer in that family. So that's very important. And those people then would have to go on checkup or routine checkup earlier than a normal average population. And then whatever the result will be, it will be taken from there. So I hope the question becomes much more easier. So yes, if you have a metastasis, if the disease is everywhere, there's no way you can cap it, but you can just try to delay the growth. But if it's around the prostate itself and the structures, the urologist said it's still curable, so you'll still be able to get the cure. But the punchline for us is that don't wait till it stops working for you to seek help. Even if it's still pumping, go check it. If it's good, it can be made excellent. Anyway, I'm going to continue with the questions now. Babumzi said, I'm loving this discussion. There was a question from Upiwe, said, which other test do you do if the blood comes back normal and the patient does not want to do biopsy, but has all the signs of a prostate cancer? So before you answer this question, please answer this one because so that we can go back. What are the signs? Because I think Babumzi missed the signs. So tell us quickly what are the signs of prostate cancer, and then we can say we answer Upiwe's question.
Okay. Yes. Most important part is early prostate cancer. There are no signs. There are no symptoms. There is no warning. That is the reason why you need to go and check even before that. But then the symptoms are usually around urination. Because if you had to look at one of the slides where we showed the prostate cancer, we showed the urethra, you can see the prostate cancer is going around the urethra. Therefore, once there's growth within the prostate, then your stream is going to go slower. You may see blood in the urine, see blood in the semen, because prostate cancer, the prostate is part of the fluid. It produces the fluid that we see in the semen. So you see blood in the semen. Waking up at night more often to go and urinate, unable to hold your urine. So with then you've got urgency, and of course it can come with erectile dysfunction.
Okay.
And then
So
the other question then would be about what other blood tests can you do in order to assess for the prostate for someone who does not want to do biopsies. Unfortunately, the PSA is the only blood test that we have currently, and in other forms of the PSA, because then maybe they can, depending what is the value of the PSA, they can then look at other forms of the PSA, because what the PSA does, it just gives us what is the total PSA in the total PSA in the blood, but then we can always look what will be what you call bounded PSA versus free PSA, and then those ratios can give us better understanding of whether there's prostate cancer or not. But another thing that's coming up now is imaging. So then, if someone does not, unfortunately, biopsy is the only way you can have a confirmed diagnosis. So another thing other than bloods can be to do an MRI before doing a biopsy. Then the MRI will tell us what is the likelihood that this is a cancer or it's something else that you are dealing with.
okay. So I hope that answers the question. Clearly, in terms of what else, we know of PSA for now, and yes. So Ustein saying it's not the fear of checking doctors, it is the fear of killing the man's pride when told that the cancer has bent the engine of manhood beyond repair. We need a pre and post counseling. We are really scared and stressed. What do you say about that?
I think the when it comes to prostate cancer, one, at some stage, the prostate cancer itself will have an effect on your erection. However, the treatments also have an effect, a negative effect on on erections. However, now once you are under the care of the urologist, then we can always work on the erections and really try to get the erections and all other things back into a working condition. Because I think as what the World Health Organizations really say about sexual health is actually quite an important thing, and we all know that when we're talking to people that we're always worried about sexual health, and it is quite an important issue.
Yeah, that's true. So one of the issues that I've just to add on erectile dysfunction is that one of the issues that I became aware of is that once abobaba or amachita realizes good to you are a doctor, they all they see is a prescription for enhancing an erection, and which also said to me, we putting a erectile dysfunction as one of those things that we get worried about, but in the same breath we are not willing to go checked on those things that can impair the erection. So we are happy to enhance, but we are not happy to check that the way we are, it's not affecting our erection up until this is a disaster, or up until now you can't even say bantwini ukuthi phela into zami zifile. So I think ukuthi next time we must when you are available and we have discussed with the team, we'll call you again just to touch on erectile dysfunction for men, but we'll then have to
And
do it. Yeah, over to you.
Just a quick word on that. Yeah,
Yeah.
I'm just gonna say just a quick word on that. That actually, erectile dysfunction is actually usually is a symptom of other things, and
Of course.
and then just getting a prescription from your doctor friend in the corridors may really be doing you a disservice, not only in terms of prostate cancer, but other diseases, diabetes, hypertension, vascular diseases that we really need to tackle.
Yeah, no, that's true. Hence, I'm saying men are willing to get the medication, but they're not willing to get checked on things that affect the erection. And it should be that you get checked so that you are healthy enough to carry whatever weapon of mass destruction and whatever that you need to do with it. So you should be able to get checked so that we can check that you are really healthy than just to collect the prescription, which is what I'm saying, that people always often look at this, and we know that most men, they pride themselves with that, and the stigmata of that we need to remove. But today we are dealing with prostate cancer, and this is the information we have. So from what you said, if you present early, you get a less radical treatment, and therefore the lesser effect on your erectile dysfunction, or on your performance, so to speak. Because you said that the disease itself can affect your potency, your erection, and also the treatment can affect your erection. But I remember very well that you said that when you have an early disease, you can put seeds where they just irradiate the prostate without taking it out. What is the effect of early presentation versus the dysfunctionality post-treatment? Does presenting early to some extent preserve your erection in terms of when it comes to treatment? What's your thoughts?
No, most definitely. Early presentation will always it helps in terms of the functioning of functionality of all the organs around, both the bladder and the erections. Because remember, even when you're doing even if you have to do a radical prostatectomy, if it's a very high volume disease, there's a lot of the cancer there. You really cannot be thinking about erections, because now it becomes life over erections. So you really need to be more aggressive in terms of your operation. Whereas early diseases, you really can take your chances in terms of preserving the nerves and everything. And of course, things like putting the seeds, like the brachytherapy, where you put the seeds, the radioactive seeds, into the prostate, also has shown has less side effect, you've got less toxicity, less side effects, and then actually very minimal side effects with that. So early detection is the key.
Yeah. So like we said, and as other people, when they're on the platform, they declare that they're feminist, and they look out for females. I also look out for the guys, abobaba, bonta, debwabuti, early presentation. The same way that early presentation in breast cancer can make you preserve your breast than to have it removed completely. The same thing with a prostate. Early presentation, the lesser effect of treatment, the lesser side effects, you still preserve your erection as it is, right? So get checked early. Now, there's another question. If you ever had an encounter where a patient refuses to be examined after being told that a rectal examination could be the basic method used to check a prostate. But hey, Baba, ngomuno wako, ungezi la. Have you ever had that?
Singabantu ngotata, we often, it becomes most of the time it's a problem that in terms of having to have the rectal examination, and some of the times it becomes, I think that's what also where the stigma about urologists also comes in, because once someone hears that you had seen a urologist, then they will know that someone has really put a finger, may have put a finger up the rectum. But honestly, it has absolutely nothing to do with anyone's sexuality or anything like that. And it is a simple test that can really assist us. It is uncomfortable. uh, it is uncomfortable, not really, not painful, but uncomfortable. And then I often say to the gentlemen that, the ladies, they go to have pap smears very religiously, and then they, with pap smears, actually far more invasive, if I were to use that word, than a rectal examination.
No, I thought you're still continuing, but um, if you say that it's uncomfortable, not everyone is going to agree with you, but I'm going to leave it at that. Anyway, we also use the rectal examination to check for rectal cancer and anal cancer and the extent of. So even the surgeons stick the fingers up. So it's something that we need to normalize as men. When you are at the doctor, if we want to check you at the back, just allow us to do that, because that's where nobody checks. Nobody will tell you if there's something, like I'm saying, you don't want to come and present while the issues already. So I think these are all the questions we have, and we are sitting at exactly at an hour's time. And I would like to thank the attendance again. As family, please help me to thank Dr. Gwiliza for offering his time to the ministry, to the family, to come and educate us as well. And like as we do, he'll be one of our familiar faces as well, because now I've already given him another assignment. And when we call men to come in together, I'm also going to call him to educate men as we do these live sessions that we're going to have, where we have discussions as men around, and discuss all the other things that are bothering us. So, men's health as well is one of the stuff that we need to touch on. And he also touched on fertility, where, the women gets to be the one that gets blamed. So I emphasize that the ladies that are on the ministry, when we have discussions like that, just give your partner some oomph to come and attend, so that we can educate your partner as well, so that certain things, they can be open-minded. And it's better when we discuss these things as men than when you are trying to initiate that discussion yourself. You might be told that you are telela by some of the Nguni men. I'm not talking ill about them. I'm a Nguni man as well. I know when I like the tendency. I mean, I'm an attenuated one. I'm a changed one. I listen. So, ladies and gentlemen, help us to thank Dr. Gwiliza for the time. And Dr., thank you very much. And if you have the offices numbers where they can call in to make an appointment, whether in private, where they can consult with you, you can go into the blog itself, and on the comment box, leave your contact there, so that they can call your office should they need anything, or should they want to hear something, or consult about anything. Don't be shy. This is what we do here. When you introduce yourself, you tell us where we can find you, because we don't pay you for the time you come here. You're doing out of willingly. But once you consult, you charge them a full rate. They must not use my name as a key to have you but your friend brought you at the discussion on In His Grace and Mercy. So much, that's how we come in. So there you can fully charge them. Here they had the chance to ask questions, and we thank you very much. I think I was expecting a lot of thank yous, ladies and gentlemen, because I know our people, but they pay attention. They pay attention. They sometimes even forget to share. They sometimes even forget to comment. They pay so much attention. You see the number sitting there that they're there. But the abanyagazi are cool. So Dr. Gwiliza, last parting shots before Sivala Baba. What last parting shots and Lento? What do you have to say?
First, thank you for the invitation and the opportunity really to come and share some of the issues about men's health, and which some of the people really know that we really talk less about, and hope today, after this discussion, maybe one or two people really, people's lives can be really saved, and quality of life can be improved. And Thank you, Dr. Kekane, for the opportunity.
Thank you, Dr. Guliza Siyabonga. Thank you, ladies and gentlemen, for thanking him. Really, it's an honor for us to have him and have him discuss these things with us. And in the absence of any comment or any questions, that means this topic is really exhausted. We have exhausted all the questions that you might have. If you still have other questions later on, you know what to do. Just post it there, or you can have you can inbox us, or you can send a WhatsApp. You know what to do. When you have extra questions in terms of whatever that we discussed, and we'll try to answer at the best of our ability. So this leaves me to thank you and bid you goodbye, like we usually do in an MK team style. Listen, I'm Dr. Kekana. I'm Pastor Kekana. We love you. We care about you. Be safe. We have a new strain that we've heard of that is on the block now in terms of the infection rate of COVID is going up. Ladies and gentlemen, take care of yourself. We are about to be hit again and again and again. I don't know till when, but we always must remember that the word and the name of God should be lifted up, because God is the one that has the final say over our lives. In the same breath, God said we perish because we lack knowledge. When the knowledge is parted, let's take it and use it at your own discretion. But keep safe. We love you. Let's see you again on Sunday. On Sunday, we've got a special service for you, somewhat special service for you. We are trying to cook it with the team. We'll see you on Sunday, 8 o'clock on In His Grace and Mercy. Let me bid you goodbye. I'm Dr. Kekana. I'm Pastor Kekana.